Med-surg management of fluid resuscitation and peritoneal dialysis. What is fluid resuscitation and who needs it? So fluid resuscitation is the rapid delivery of fluids to patients who have acutely impaired hemodynamics. Resuscitation are given usually to patients in hypovolemic shock and lesser form of dehydration, as well as to almost all patients with severe sepsis and septic shock. Conventionally, patients are given fluid resuscitation if mean arterial pressure is less than 60 to 65 mm mercury and or central venous pressure is less than 8 mm mercury plus no evidence of cardiogenic pulmonary edema. However, neither the MAP nor CVP nor other static measurements are good predictors of which patients will benefit from IV fluids. There are three important terms that we should note. That would be isotonic, hypotonic, and hypertonic. For most, it is important to note that these terms are what we call the relative. So we measure the tonicity in relation to another value. In this case, we use the tonicity of the plasma in our body as the relative value. And we measure everything based off of the tonicity of our body plasma. And when we say tonicity, this is the capability of a solution to modify the volume of cells by altering their water content, also known as the osmosis. And isotonic is, when we say iso, means same. So isotonic solution will have similar or the same tonicity as our plasma volume or our plasma fluid. And for the hypotonic solution, it's the opposite. So this solution have a lower solute concentration than our body's plasma. And with the hypertonic solution, this is a higher concentration of solute as compared with our body plasma. There are two types of fluids that most commonly used in the hospital setting. First is the crystalloid. So it is an aqueous solution with varying electrolyte composition, used mostly to increase the vascular fluid volume. You would choose crystalline that you are using based on the electrolyte composition as well as the patient's status. So if the patient has specific pathologies that create like electrolyte deficiencies or etc., you could choose the crystalloids that would help to alleviate or fix those deficiencies. On the other hand, colloids is the highly molecular weight fluids that remain confined in the intravascular space that cause a shift in oncotic pressure and used as fluid volume expander. Crystalloids is more like water. Colloids is much heavier. It says colloids is a volume expander because they cause a bigger shift in a shorter amount of time. Things to remember for the identification of IV fluid resuscitation is first is the replacement of free water deficit, replacement of ongoing fluid losses, maintenance fluid therapy, correction of electrolyte imbalance, and as a solvent vehicle for IV drug administration. So there are certain drugs that we administer that are called caustic, and that means they can or have the ability to damage the veins. So this drug administered via IV or mix them some fluids in order to ease the way and a bit easier for the patients and less painful. But it requires solvent in order to be more efficiently administered. For the table of solution for parenteral administration, we have different types of solution and its electrolyte composition. But here I'll be go over to different types of solution and its osmotality. First is extracellular fluid, and its osmotality is 280 to 310. Lactated rangers, 273 osmotality, 0.9% sodium chloride, 308 osmotality, D5.45% sodium chloride, 407 osmotality, dextrose 5% water, 253 osmotality, 3% sodium chloride, 1026 osmotality, and plasma latte is the 295 osmotality. D5 is a 5% dextrose, and D5W is dextrose in water. In isotonic solution, is belong here the plasma latte, lactated rangers, and D5 water, and normal saline. So uses for this isotonic solution, we have the GI losses, extracellular volume deficit. Lactated rangers is likely hypotonic because it contains lactate in order to render it more stable storage. For the sodium chloride, ideally used for volume deficit associated with hyponatremia, hypochloremia, and metabolic alkalosis. Fluids are not just giving you water. You're technically giving a drug in the sense that you have to consider that there will also be complications as a result of you giving these fluids. So in sodium chloride, that is mildly hypertonic because it has an increased amount of concentration of sodium balance with also an increased number of chloride or increases concentration of chloride, which leads to increases the chloride load in the kidneys and may lead to hyperchloremic metabolic acidosis. Plasma latte. This is a closest to the complication of human plasma but contains small quantities of potassium. It's used in the caution of patients with renal impairment or risk for renal impairment. Dextrose 5% water. This is the caution for hyperglycemia in diabetic patients. And lactated rangers, complication for lactic acidosis in those with liver failure. Remember, do not administer lactated rangers with blood product because it causes clumping in the blood products. We have different types of solution under alternative resuscitative fluids. So we have the hypertonic saline, albumin, dextran, hetastarch, hextrate, gilofuscin that will be further identified. The second type of IV fluid solution is the hypertonic solution. So this is the hypertonic saline solution with 3.5% sodium chloride and 5% sodium chloride. It uses is to correction of severe sodium deficit, treatment in closed head injuries. For the complication, we have the increased risk for bleeding because it acts as a arteriolar vasodilator and osmotic myelinolysis. So this OM is an acute or non-inflammatory demyelinating disease that can develop following rapid correction of hyponatremia from any cause. And the third type of IV fluid solution is the hypotonic solution. It has 0.5% sodium chloride or 1/2 normal saline or 1/2 NS. Its uses is replacing free water deficit, and note that it is no longer recommended for use as a maintenance fluid therapy. For the complication, we have the cerebral edema and the pulmonary edema. Colloidal solutions. It has 4 types: the albumin, dextran, hetastarch, and the gelatin. Also, it is important to note that albumin and dextrans, these are the naturally occurring, and the hetastarch and gelatins are synthetic. Its uses is to confine to intravascular space because of molecular weight, more efficient transient plasma volume expansion. But these don't last very long, so if you want something that was going to expand our volume right away, example, a severe burn patients or someone who has completely volume kind of hypovolemic, we would start with the use of albumin or dextrans in case of our burning patients. So we start up albumin and we can use them in conjunction with crystalloids like normal saline or lactated rangers to help or continue and maintain that expansion of the volume. Colloidal solution complications. So in more severe condition like hemorrhagic shock, increase in capillary permeability allow colloids to enter the interstitial space, which leads to worsened edema and as well as impaired tissue oxygenation. These solutions are significantly more expensive, sometimes used in a conjunction with crystalloid to initially expand the volume and then maintain that volume expansion. The first type of colloidal solution is albumin, which is a naturally occurring for the specific uses for specific use for severe burns, hypoalbuminemic states, spontaneous bacterial peritonitis, acute lung injury, diuretic resistance nephrotic syndromes, and plasmapheresis as an exchange volume. It's also, and the volume remains expanded for only 16 to 24 hours. So you can use this albumin initially, and then you would kind of give an NS or normal saline or lactated dringers in order to balance it out. Dextrans is highly branched polysaccharide molecules, and its specific uses is to improve microcirculatory flow in microsurgical reimplantation. It they use this fluid to improve vascular flow in those smaller vessels. It also uses to prime the extracorporeal circulation during cardiopulmonary bypass. What they mean by extracorporeal circulation is that it helps to prime the machine or tubing that is used to pump blood. Its volume remains expanded for only 6 to 12 hours. Next is the gelatin, where it's synthesized by collagen hydrolysis. A specific uses of gelatin is for acute management of hemorrhagic hypovolemia, priming extracorporeal circulation, volume preload before regional anesthesia, and its volume remain expanded for less than 6 hours. The last type of colloidal solution is the hydroxyethyl starch. It's derived from amylopectin or highly branched starch. Its specific use is for acute management of hemorrhagic hypovolemia, and its volume remain expanded for only 8 to 12 hours. IV fluid administration consideration when determining the type of fluid to be used, and it is important to know that volume status of patients, severity of concentration, solute and plasma, composition of the abnormality presence, which mean basically to know whether or not that the patient is normal bulimic, hypovolemic, or euvolemic, and also to know whether or not they have any deficit with regards to their electrolytes. That make sure you need to check their lab result, or whether or not they have certain things like deficiencies that need to be corrected. Also consider the comorbidities of the patients. If the patient is hypertensive, if the patient has CHF or any sort of renal issues, and as well as other pathologies that can contraindicated to the administration of IV fluids. So patients with CHF or renal problems, so these types of patients that should not want to have an overloads of fluids. So you can use of something else way to give them a bolus without really providing them with maintenance, or you can titrate the rate to lower the rate. So these are the things that we consider this to our patient before we prescribe or order their IV fluids. Increased loss of fluid is a setting where the patient is acutely unwell, whether in ED or in the ward. So the patient should be assessed using the ABC's principle: airway, breathing, and circulation. Airway is assessed by talking to the patients as their name and age if they're able to answer without difficulty. So their airway is clean. And for the breathing is assessed by counting the RR, respiratory rate. It should be greater than 20, and applying a stat monitor and auscultation. If the patient is into keep-neck, that might be a sign that the patient is in volume down. And on the other hand, if you hear crackles while auscultation, that might be indicate fluid overload. The next to assess is the circulation. For instance, there is a patient and you're standing at the edge of the bed looking at this person. So you monitor the blood pressure, and their systolic blood pressure is low. And when you were feeling their pulse, you notice that their hand is cold. And so you press on their nails and found out that their capillary refill is delayed. And according to the NICE guidelines, if your respiratory rate is more than 90 and your systolic blood pressure is lesser than 100, that is the sign that you might need a fluid resuscitation. So what will you do next? Now it's time for you to insert 2 large bolus IV cannulate in their antecubital fossa and take blood, a fiber count or FBC, urine and electrolyte, coagulation, LFT, liver function test, and blood for cross-matching or XM. And in the other hands, you'll run for fluids. So what kind of fluids? Well, the first initial resuscitation is the crystalloids, which is way better than those colloids as long as the sodium content is 130 to 154 millimoles per liter, which gives us the choice between Ranger's lactate or normal saline. It doesn't matter which one you choose, whatever is available as long as it's warm and as long as it's stopped. So you get 500 ml first bolus in less than 15 minutes. And then reassess the patient's ABCs. If this patient is still not better, you can repeat the 500 ml boluses until you reach 2 liters. At which point, if the patient is still not better, that's the time you can call an expert. Whenever you feel out of depth, and especially if your patient is old and has cardiac or kidney issues, or if they have so, then try giving them smaller boluses of 250 ml. And one way of assessing the fluid loss is to raise the patient's leg up by 45 degrees, and if their BP and heart rate improves, then that's mean that they would benefit from the fluids. Just try to remember never add potassium to the recessed fluid bags and don't resuscitate with fluids containing a lot of potassium. And try replacing blood for blood. For D&E for completion's sake, so disability can be monitored through the Glasgow Coma scale. So if the patient is confused, that might give you a clue into a decreased perfusion to the brain, which could be due to the fluid loss, and exposure will help you identify any open wounds or stomas from where the arm might be losing that fluids. Peritoneal dialysis. So this is a type of dialysis which uses the peritoneum in a person's abdomen as the membrane through which fluid and dissolved substance are exchanged with the blood. So it is used to remove excess fluid, correct electrolyte problems, and remove toxins in those with kidney failure. So in peritoneal dialysis, this is where we instill hypertonic dialysate solution into the patient's peritoneal cavity. And we allow that to dwell because it's hypertonic. It will draw in excess fluid from the body. And then after the prescribed amount of urine of time for dwelling, we allow it to drain into a drainage bag. And that will remove excess fluid and waste products. So, in terms of nursing care prior to the procedure, we want to assist our patient's way. We want to warm the dialysate solution, and then we want to use sterile technique when we are assessing the catheter insertion site. Once we all set up and we allow the dialysate solution to dwell, and then we are going to drain it. We want to make sure we are keeping the outflow lower than the patient's abdomen. Also, we want to monitor the color of the outflow from the catheter. So it should be clear or light yellow. If the outflow is bloody or cloudy, that can be possible infection. And for the complications of peritoneal dialysis, we have the peritonitis. It is an important one to know since this is an infection of the peritoneal, which is the serous membrane that surrounds the abdominal organs. Signs and symptoms of peritonitis include fever, a cloudy outflow from the peritoneal dialysis, as well as the nausea and vomiting, and abdominal pain and tenderness.